Welcome to this video about monoclonal immunoglobulin deposition disease, or MDD. This rare and often overlooked condition falls under the umbrella of monoclonal gammopathies, disorders characterized by the overproduction of a single type of immunoglobulin, also known as a monoclonal protein or M protein, by abnormal plasma cells. While multiple myeloma and Waldenstrom macroglobulinemia are well-known examples of monoclonal gammopathies, MDD presents a unique challenge as the M protein, or fragments thereof, deposit in various tissues, causing organ damage. In this video, we'll delve into the intricacies of MDD, exploring its causes, mechanisms, diagnosis, treatment, and what the future holds for those affected by this complex disease. The precise cause of MDD remains elusive in many cases, often classified as idiopathic. However, we know it arises from an underlying clonal plasma cell disorder. This means a single abnormal plasma cell starts proliferating uncontrollably, producing excessive amounts of a single, identical immunoglobulin or a fragment of it. Several factors have been implicated in the development of these plasma cell disorders, including genetic predisposition, environmental triggers, and chronic inflammatory conditions. In some instances, MDD is associated with other hematologic malignancies, such as multiple myeloma or lymphoproliferative disorders, highlighting a potential link between these conditions. Medications or treatments may, in rare cases, contribute to the development of the underlying plasma cell disorder. The hallmark of MDD is the deposition of monoclonal immunoglobulins or their fragments in tissues. These deposits primarily affect the kidneys, leading to kidney dysfunction, but can also involve other organs such as the heart, liver, and peripheral nerves. The exact type of immunoglobulin involved varies, with light chains, heavy chains, or complete immunoglobulin molecules capable of forming these damaging deposits. The deposits trigger a cascade of events, including inflammation, fibrosis, and cellular damage within the affected organs. In the kidneys, for example, immunoglobulin deposits can thicken the glomerular basement membrane, impairing filtration and leading to proteinuria, or protein in the urine. Over time, this chronic damage can progress to end-stage renal disease. The specific location and type of deposit dictates the clinical presentation and severity of organ involvement. MDD is a rare disorder, and its precise prevalence is difficult to determine. Due to its often subtle presentation and diagnostic challenges, MDD is likely underdiagnosed. It affects individuals of all ages, but is more commonly diagnosed in middle-aged and older adults. There is no known significant gender or ethnic predilection. Given the association with underlying plasma cell disorders, populations at higher risk for these conditions, such as older adults, may also be at a slightly increased risk for developing IDD. The rarity of MDD underscores the importance of raising awareness among healthcare professionals to improve early diagnosis and management. The signs and symptoms of MDD are highly variable depending on the organs affected by immunoglobulin deposition. Renal involvement is the most common manifestation, leading to proteinuria, hematuria, or blood in the urine, and progressive kidney dysfunction. This can present as swelling in the legs and ankles, fatigue, and changes in urine output. Cardiac involvement can cause heart failure symptoms like shortness of breath, chest pain, and an irregular heartbeat. Liver involvement may lead to elevated liver enzymes, jaundice, or abdominal swelling. Neuropathy or nerve damage can manifest as numbness, tingling, or weakness in the extremities. Less common symptoms include gastrointestinal problems, skin lesions, and visual disturbances. Due to the multi-system nature of MDD, patients may present with a combination of these symptoms, often making the diagnosis challenging. Diagnosing MDD requires a high degree of clinical suspicion, especially in patients with unexplained organ dysfunction, particularly kidney disease, and evidence of a monoclonal protein in the blood or urine. Initial diagnostic steps include serum and urine protein electrophoresis with immunofixation to detect the presence of a monoclonal protein. A kidney biopsy is often crucial to confirm the diagnosis and identify the specific type of immunoglobulin deposit. The biopsy specimen is examined under a microscope, and specialized staining techniques, such as immunofluorescence, are used to identify the deposited immunoglobulins. Bone marrow aspiration and biopsy are performed to assess the presence and extent of the underlying plasma cell disorder. Additional tests, such as serum-free light chain assays, may be helpful in monitoring disease activity and response to treatment. Cardiac or liver biopsies may be necessary if these organs are suspected to be involved. MDD is broadly classified based on the type of immunoglobulin involved in the deposits. The most common types include light chain deposition disease, or LCDD, where monoclonal light chains, typically kappa or lambda, are deposited, heavy chain deposition disease, or HCDD, involves the deposition of monoclonal heavy chains. Light and heavy chain deposition disease, or LHCDD, involves the deposition of both light and heavy chains. The specific type of immunoglobulin deposition can influence the clinical presentation and prognosis. Furthermore, MID can be classified based on the presence or absence of a concurrent plasma cell proliferative disorder, such as multiple myeloma. In some cases, MIDD may be the sole manifestation of the clonal plasma cell process, while in others, it coexists with a more established hematologic malignancy. The treatment of MIDD is primarily aimed at suppressing the underlying clonal plasma cell disorder and preventing further immunoglobulin deposition. The specific treatment approach depends on the type and severity of MID, the organs involved, and the presence of any concurrent plasma cell malignancy. Chemotherapy regimens, often similar to those used for multiple myeloma, are frequently employed to reduce the production of the monoclonal protein. Proteasome inhibitors, immunomodulatory drugs, and alkylating agents are commonly used chemotherapeutic agents. In some cases, autologous stem cell transplantation may be considered, especially for younger, otherwise healthy patients. Supportive care is crucial to manage the symptoms of organ dysfunction. This may include dialysis for kidney failure, medications to manage heart failure, and pain relief for neuropathy. Regular monitoring of organ function and monoclonal protein levels is essential to assess treatment response and detect any disease progression. Currently, there are no specific preventive measures for MIDD, as the exact causes are not fully understood. However, maintaining a healthy lifestyle, avoiding exposure to known environmental toxins, and managing any underlying medical conditions may help to reduce the overall risk of developing plasma cell disorders. Early detection and treatment of any associated hematologic malignancies may potentially prevent the development of MIDD in some cases. Individuals with a family history of plasma cell disorders may consider genetic counseling to assess their risk. The prognosis of MIDD is variable and depends on several factors, including the extent of organ involvement, the type of immunoglobulin deposited, the underlying plasma cell disorder, and the response to treatment. Early diagnosis and aggressive treatment can improve outcomes, but advanced organ damage may be irreversible. Renal involvement is a major determinant of prognosis, with progression to end-stage renal disease being a significant concern. Recent research efforts are focused on developing more effective therapies to target the underlying plasma cell disorder and prevent immunoglobulin deposition. Novel agents, such as monoclonal antibodies targeting specific plasma cell antigens, are being investigated in clinical trials. Furthermore, advances in diagnostic techniques, such as mass spectrometry, are improving the ability to identify and characterize immunoglobulin deposits, leading to more precise diagnosis and personalized treatment approaches. Continued research is essential to improve the understanding of MID and develop more effective strategies for prevention and treatment, ultimately improving the lives of those affected by this rare and challenging disease.